Before we begin, I would like to do a land acknowledgement. Today, we would like to acknowledge that we are on the land on which we are gathered today is the traditional territory of the Anishinaabe Nation, specifically the Chippewa Tri-Council, comprised of Chippewa of Beausoleil Island, Rama, and Georgina Island First Nations, and most recently, the Mississaugas of the Credit River First Nation. Ontario is covered by 46 treaties and other agreements and is home to many Indigenous nations from across Turtle Island, including the Inuit and Métis. These treaties and other agreements, including the One Dish with One Spoon Wampum Belt Covenant, are agreements to peaceably share and care for the land and its resources. Other Indigenous nations, Europeans, and newcomers were invited into this covenant in the spirit of respect, peace, and friendship. Most of us have come here as settlers, immigrants, or newcomers in the generation or generations past. We are all treaty people. Every day, we are mindful of broken covenants, and we strive to make this right. We commit to collaborating based on the foundational assumption that Indigenous people have the power, strength, and competency to develop culturally specific strategies for their communities. We are dedicated to honoring Indigenous self-determination, history, and culture, and are committed to moving forward in the spirit of reconciliation and respect with all First Nations, Métis, and Inuit people. Okay. Today we are here for our session on delirium and a part of our current series with the Palliative Care Echo Project. The Palliative Care Echo Project, as most of you know, is a 5-year national initiative to cultivate community practice and establish continuous professional development amongst healthcare providers across Canada who care for patients with life-limiting illnesses. So thank you for being here today. And a special thank you goes out to Health Canada. We would not be able to provide this service, these sessions, without the financial assistance we receive from Health Canada for the ECHO project. And now for some introductions. For those of you who this is your first time joining us, my name is Amanda Tavelda. I am Communications, Fundraising, and Community Relations Specialist with Hospice Aurelia. And our hosts today are Kathy McEwen and Sue Martin, both who are hospice palliative care nurse consultants with the North Simcoe Muskoka Hospice Palliative Care Network. Ladies, the floor is all yours.
So the learning objectives for today will be to discuss the etiologies of delirium and the characteristics of the various subtypes, define the syndrome of delirium, review the clinical assessment and tools used, and identify the non-pharmacological and the pharmacological treatments. Throughout this presentation, though, the medications we often refer to as antipsychotics, like haloperidol, will also be referred to at times as neuroleptics, as per the CCO guidelines. We apologize in advance for any confusion during this presentation.
Has anyone ever documented or read a comment indicating that a patient has is pleasantly confused? There's a misperception that delirium can be just pleasant confusion, and therefore sometimes it's not investigated or the investigation is delayed. In this study by Bruberry et al., 54% of patients whose delirium resolved recalled the delirium experience, and 80% found it highly distressing. There have been current reports of patients surviving ICU admissions with COVID-19 who report extremely distressing, frightening memories related to their delirium during a medication-induced coma. Their delirium are memories due to the brain not receiving enough oxygen, blood pressure, or food. There has also been reports from post-heart surgery patients who have had the same experience of distressing memories related to medication-induced coma.
Cancer Care Ontario defines delirium as a transient organic brain syndrome characterized by an acute onset of disordered attention and cognition, accompanied by disturbances of cognition, psychomotor behavior, and perception. And this is the definition for delirium from Pallium Canada. So DSM-5 criteria These 4 criteria should be met to make a delirium diagnosis. That's disturbances in the inability to focus and affect attention. It develops over a short period of time. There is a change in their cognition, and there is evidence of a medical condition related to this disturbance.
So the pathophysiology. Delirium, an acute confusional state, which is defined by a disruption of consciousness, a decrease of cognition due to decreased ability to focus, and over or under activity, lethargic or agitated. Hallucinations or intrusive thoughts may be present. Delirium is transient, over hours to days. The mechanisms of delirium are not fully understood. The thought is that delirium is due to reversible impairment of cerebral oxidative metabolism and multiple neurotransmitter abnormalities. Pathophysiology occurs in a reticular activating system. The RAS, or the RAS, is a collection of neuronal clusters in the thalamus, pons, medulla, brainstem, and other locations. The reticular activating system is responsible for our wakefulness, ability to focus, and our fight-flight response. RAS is dependent on neurotransmitters, primarily acetylcholine and norepinephrine. If there are things that change or interfere with acetylcholine or acetylcholine receptors or norepinephrine levels, it will impact the function of the reticular activation system. Interestingly, the elderly have atrophy and decreased activity in the RAS, therefore are more prone to developing delirium. Many things can impact acetylcholine levels and other neurotransmitters, such as medications, infection, stress response, disruption of sleep-wake cycle, vitamin deficiencies, and electrolyte imbalance. Stress of any kind upregulates sympathetic tone and downregulates parasympathetic tone, impairing cholinergic function and thus contributing to delirium. Regardless of the cause, the cerebral hemispheres or arousal mechanisms of the thalamus and brainstem reticular activating system becomes impaired. So under prevalence, 25 to 85% of palliative care patients who are dying experience symptoms associated with restlessness before death. Delirium at end of life is thought to be a result of metabolic encephalopathy resulting from organ failure, electrolyte imbalance, nutritional abnormalities, or sepsis. In general medication, approximately 1/3 of hospitalized older patients experience delirium. In the ICU, 50% of patients experience delirium. 56% of people with dementia are likely to experience delirium, and 90% of coma survivors report delirium experiences. Delirium impacts more than 7 million older adults in the United States each year. The annual costs attributable to delirium in the US alone are $160 billion. Globally, dementia costs approximately $1 trillion annually. Delirium has been associated with varied negative outcomes like prolonged hospital stay and increased mortality, the need for institutional care, poor functionality, and high treatment costs. It has also been shown to be associated with high short-term and long-term mortality. Delirium is very distressing to patients, families, and the caregivers. An agitated delirium can leave a very lasting, distressing memory. Patients with delirium can't describe their symptoms properly. It alters symptom perception and expression, making symptoms more difficult to assess and manage. The verbal cues, for instance, moaning and groaning, may be mistaken for pain, resulting in further increases of analgesic, which might in turn exacerbate the delirium if it's due to or aggravated by the opioid use. Delirium is associated with cognitive decline and development of dementia. Delirium is a medical emergency in palliative care. This quote from an article by Lee et al. Is one of many, many studies which support the fact that there is a high incidence of delirium, particularly in the older population, and that we as a whole are not great at identifying someone with delirium, and that we could and should do much better at prevention. So there can be challenges in diagnosing delirium due to the fluctuations in presenting signs and symptoms. Sometimes delirium is confused with dementia or depression. Delirium could be superimposed on a pre-existing dementia, or hypoactive delirium can easily be mistaken for depression. The onset of delirium is rapid, hours to days. The onset of dementia is very gradual, months to years. The onset of depression is gradual in terms of weeks to months. The illness course for delirium fluctuates. In dementia, the course is generally stable with periods of behavioral problems such as sundowning. And in depression, the course is generally stable. The presenting features in delirium are lack of attention and concentration. In dementia, memory loss is present. And in depression, cognition might be affected. But this here is a great tool to aid in determining diagnosis. Kathy is going to speak to the etiologies of delirium.
This is the delirium mnemonic tool that can be used to assist in identifying the etiology of a delirium. Delirium may have a single cause or more than one cause, such as a medical condition alongside with a drug toxicity. Usually there are at least 3 causes per episode, and sometimes no cause can be identified. Using the mnemonic, the D would represent drugs and dehydration. E would represent electrolytes and endocrine disorders such as thyroid and adrenal dysfunction. There's alcohol and or drug use and abuse or withdrawal. L would represent liver failure. I looks at infections such as pneumonia, sepsis, and UTIs. R was respiratory problems and urinary or stool retention. I for increased intracranial pressure. U for uremia or renal failure and undertreated pain. And M would be metabolic diseases, brain mets, medications, and malnutrition, such as vitamin deficiencies of thiamine, folate, B12. So risk factors combined with precipitants will increase the risk for delirium. Diseases often cause a chronic inflammatory state, and those cytokines that are produced from this inflammatory state can interfere with brain dysfunction. Other clinical symptoms would be an inability to focus, sleep disturbances, disorientation, agitation, and reduced activity. There can be altered awareness and level of consciousness, hallucinations, delusions, or paranoia, disorganized thoughts, and memory deficits. And this diagram discusses the clinical subtypes of delirium. Hyperactive is basically characterized by heightened arousal or restlessness, agitation, delusions, and or aggressive behavior. They can be seen to be picking at the air or trying to get up and having pointless movement. Hallucinations are witnessed in up to 22% of hyperactive deliriums. Hypoactive would present as being somnolent or withdrawn, and they would have no agitation. They have a reduced sense of awareness of their surroundings, and it's often mistaken for depression. Up to 50% of delirium cases may be hypoactive and have a higher mortality rate than the hyperactive delirium. And then we have the mixed, and it's characterized by alternating between the hyper and the hypoactive behaviors. These can be subdivided into a mild, moderate, and severe presentation. There is no standard. Delirium designation of mild, moderate, and severe can also be thought of as how distressing these symptoms are for the patient and the family. Severity can vary throughout the day. You should be watching for sundowning, as it can be a sign of an early delirium. It's often misdiagnosed as uncontrolled pain. Delirium tremens would be seen in alcohol withdrawal. Excited delirium is usually precipitated by stimulants such as methamphetamines or cocaine, and they can often result in sudden death. We also have post-op deliriums and then subsyndromal delirium. These are patients who have signs and symptoms, but they don't meet the diagnostic criteria for delirium. These patients should be monitored closely, as a full-blown delirium may be evolving. Benzodiazepine should also be avoided with these patients.
Thanks, Kathy. So the overall management approach, what's our plan? Firstly, we need to screen for delirium on a regular basis. Then we need to confirm the diagnosis. This requires a clinical assessment history, and clinical exam based on the DSM-5 criteria. Once diagnosis has been confirmed, we need to do three things simultaneously. We need to identify and treat the underlying causes. We need to manage the symptoms, and then we need to educate the patient, family, and caregivers. This is all dependent on where the person is on their illness trajectory, what their wishes are at end of life, the goals of care, the advanced planning, also the setting and expected reversibility of the underlying cause. Prevention is important as well. Some suggestions to prevent delirium: reduce polypharmacy, avoid psychoactive and anticholinergic medications, prevent dehydration, and increase mobilization. Given the fact that there's a high incidence of delirium, the huge impact that it has on the patient and family, and the fact that it's very often missed, it is essential to screen for delirium regularly, utilizing the interdisciplinary team. Early recognition and treatment can improve outcomes, and there are a number of tools available for screening delirium. So there's the 4AT, the NuDesk, the CAM, and the ESAS-R. This is the 4AT. It's a simple to use, takes less than 2 minutes. It's a well-validated bedside tool. It helps practitioners detect delirium in day-to-day practice. The NuDesk, or the Nursing Delirium Screening Scale, was developed in 2005. It's designed to use at the end of the shift to identify patients with delirium. It takes 1 or 2 minutes to complete based on an 8-hour period of observation. The CAM, or the Confusion Assessment Method, helps identify individuals who may be suffering from delirium or an acute confusional state. It's useful for distinguishing between delirium and dementia. The CAM is a validated delirium screening and diagnostic tool, and it's easy to use and can be completed in less than 5 minutes. The ESAS-R, we've included the ESAS-R because although the patient may not be able to report symptom scores themselves, it's still a useful tool to discuss symptoms with the family. Families can provide insight into recent changes, for example, pain, which might be an underlying cause, along with anxiety or drowsiness. Kathy's going to talk a little bit about comprehensive symptom assessment and tools.
Thanks. So the components of a comprehensive symptom assessment, we are going to want to take a good history from the patient if he is able to give it to us, and the family. A good physical assessment needs to be done, and medication reviews should be also reviewed. Investigations and treatment should be discussed with the family and the patient if able. So what are the patient's goals of care? Physicians should also be discussing the overall disease burden, what the patient's life expectancy is, where is he in his illness trajectory, the probability of reversibility, and what the patient or the family wishes are and the setting of care, the availability of some investigations and the burden of those investigations for the patient. Delirium is caused by extensive brain mets for severe hepatic failure, is unlikely to be reversed. So Cancer Care Ontario, this is their algorithm on delirium. This is their first page. And at the top, we have the OPQ, RSTU, and V acronym. It is suggested assessment questions. These suggested assessment questions need to be tailored for each patient. When the patient is not able to participate in the assessment by self-reporting, then the healthcare professional and/or the caregiver may act as a surrogate. The delirium acronym right underneath may assist healthcare providers in quickly identifying or reviewing the multiple factors that could cause or contribute to a delirium, and interventions for all patients as appropriate by the underlying cause of the delirium can correct reversible factors like infections, constipation, pain, withdrawal, and drug toxicity. Treat the underlying cause. It's important to communicate with the family to reassure them that this is the illness that is presenting with these client behaviors. Really reassure them that the client is not going crazy. It is important to include the family in these decision-making. emphasize shared goals of care, and support the caregivers. Delirium interferes with patients' ability to self-report symptoms such as pain. It is also important to understand that some hallucinations, nightmares, and misperceptions may reflect unresolved fears, anxiety, or spiritual passage. And Cancer Care Ontario algorithm on delirium, page 2. This covers the non-pharmacological measures that should be implemented with all delirium patients. It doesn't matter whether they're presenting with a mild or severe delirium. We should be using these steps first. And then pharmacological measures for mild, moderate, and severe care pathways for treatment per CCO guidelines are right below. When treatment is not effective, it would be best to consult with a palliative care expert, such as a palliative care physician or a palliative care nurse. So ongoing comprehensive assessment is the foundation of effective management of delirium. Using the OPQU-RST, U, and V, we would look at onset. We would want to know, when did it begin and has it happened before? Palliating and provoking. Are there things which worsen the agitation, and what might make it better? How are you sleeping? Quality. What does it feel like? Do you feel confused, or are you seeing or hearing anything unusual? Region and radiation. Do you know what day it is, the month, the year it is? Do you know where you are right now, and can you tell me your full name? Severity. What is the intensity of this symptom? For treatment, what medications or treatments are you currently using, and how effective are these? Do you have any side effects from these medications or treatments? And understanding, what do you believe is causing this symptom? How is the symptom affecting you and your family? And values, what is your goal for this symptom? Where severity and value indicators are listed here, they all request a numerical value. Often with these patients, they're confused and they're not able to give us that information. That's when they're talking about tailoring some of these questions to each patient as an individual. Richmond Agitation Sedation Scale is the RAS. It is a 10-point scale ranging from -5, which is unarousable, even with no response without physical stimulus. 0 is the alert and calm, and +4 would be combative. This test measures the intensity of symptoms. It's normally assessed daily and suggested to measure throughout the day. It should be assessed every shift to assess fluctuations in symptoms. And these tools are really great tools here to screen for cognitive impairment, but they're not so much they're not so much for delirium, more for cognitive impairment. And pharmacological and non-pharmacological treatments will be started with Sue, and I will both be covering this.
We work together. When treating underlying causes, consider investigation and treatment through the lens of potential benefit versus burden for each possible treatment. The decision to treat depends on the illness trajectory, the person's wishes, values, and access to investigations. Treatment may not be appropriate at the very end of life. Sometimes it's just not possible to treat the underlying cause. Reversibility is more likely earlier in the illness, a 60 to 80% chance of reversal. But if a person has hours or days, there's a 20 to 40% chance of reversing that delirium. Medication review, blood work, urinalysis, and imaging may be helpful to determine the cause of the delirium. Excuse me. This tool here is a great resource from Pallium to aid in establishing appropriate interventions. Sometimes it is unclear if the treatment might reverse delirium. For instance, with dehydration as the underlying cause, you may consider a therapeutic trial of hydration for 2 or 3 days, or maybe for infection, trial an antibiotic. If it's ineffective after the trial, then you can discontinue the treatment. But this plan needs to be discussed prior to initiation with the patient and the family. Of note, with hepatic encephalopathy, lactulose is of limited benefit in the last days of life. And while steroids are often helpful in brain metastases, Steroids have also been known to cause some delirium. Remember, we need to do these three things simultaneously. We need to identify and treat the underlying causes. We need to manage the symptoms, which may include agitation, hallucinations, or maybe paranoia. And we also need to provide health teaching to the patient, family, and caregivers. Non-pharmacological management approaches should occur for all patients. Medication management should be reserved for those patients who have a severe delirium or if they're at risk of harming themselves or harming others. With non-pharmacological treatment, encourage a family member or a friend to be present at the bedside. Provide gentle, repeated reassurance. Provide a calm, reassuring tone in communication. There should be no arguing with the patient. Attempt to reorient the patient to person, place, time. Use a calendar, use a clock, use familiar items. Reduce stimulation, limit activity and visitors in the room, minimize staff changes and room changes. We do that a lot sometimes in hospitals. Remove unfamiliar bedding, pictures on the wall, TV, phone. Provide low ambient light in the room or allow natural light. Restraints or bed alarms may add to the confusion, and avoid catheterization unless the patient is in urinary retention. Think about sleep hygiene. Keep lights low. Provide a night light, but never leave the person in total darkness, and keep the noise level low. Correct reversible factors such as dehydration or nutrition, and be sure hearing aids, glasses are in place. Encourage activities that they enjoy, such as music, massage, or a warm bath. Encourage activity if the patient is physically able with appropriate mobilization or ambulation. Consider positioning during and after oral intake, and provide comfortably loose clothing. Think about the environment. Is the temperature comfortable? Minimize or avoid exposure to nauseous smells or sights. Always invite the presence of a well-known family member.
So
Right.
today we are referencing the CCO management guidelines, but be aware there are other valuable resources such as Pallium. Haloperidol is the gold standard for treatment of delirium, and it is the most commonly used antipsychotic in the palliative care setting. If a delirium occurs in a patient with Parkinson's disease or Lewy body dementia, avoid the typical antipsychotics such as haloperidol. Consider a sedative such as clonazepam or an atypical antipsychotic like quetiapine, which has a lower anti-dopamine activity. Benzodiazepines are considered second-line agents and should only be used in cases of alcohol withdrawal or if the patient has a history of neuroleptic malignant syndrome and therefore should not take antipsychotics. So, navigating mild delirium. These are the medications and the dosages and the alternate agents indicated for the treatment of mild delirium per CCO guidelines. Again, here's some more alternate agents that can be used in treating mild delirium. And these also are medications that you would use, and the dosages and their alternate agents also that would be indicated for a moderate delirium per CCO guidelines. Also in moderate delirium, diazepines may paradoxically excite some patients. It should be avoided unless the source of the delirium is alcohol or sedative drug withdrawal or when severe agitation is not controlled by a neuroleptic. In severe delirium, this would be the steps you would take per CCO guidelines. If the agitation is refractory to high-dose neuroleptics, consider adding lorazepam or midazolam in conjunction with that neuroleptic. And again, here's some alternate agents that CCO guidelines have been laid out for these patients, such as methotrexate and chlorpromazine. And if the above isn't effective, you can use haloperidol, 10 milligrams sub-Q, noting that haloperidol 20 milligrams per day is the maximum dose usually. And methotrimeprazine, we can try to use that at 25 to 50 milligrams sub-Q every 6 to 8 hours, every hour PRN. And this is for severe delirium. If delirium is severe and this symptom, the symptoms are refractory, it's a refractory delirium, treatments with palliative sedation might be an option as long as the patient meets the criteria for palliative sedation. Palliative sedation should be initiated under the guidance of an advanced palliative care, someone who has advanced palliative care skills.
Thanks, Kathy. At the same time, okay, we have identified and treated the underlying causes. We are managing the symptoms pharmacologically and non-pharmacologically. Now we need to educate and discuss the patient, the family, and the healthcare providers. Education is key. An informed caregiver will be better able to recognize the subtle changes in cognition, which can be helpful in the diagnosis of delirium. Family can participate in non-pharmacological management, such as reorienting the patient using familiar objects. They often have more detailed information about what the patient likes and dislikes and what the usual activities are. The Hospital Elder Program is a delirium prevention program designed to improve the hospital experience of older patients, and it has been implemented internationally. The program strives to support enrolled patients up to 3 times daily, 7 days a week, by providing daily visiting with the goal of increased orientation and social support, early mobilization by encouraging patients to keep moving, hearing and vision support by offering access to glasses and hearing amplifiers, therapeutic engagement through meaningful activities that keep the brain active, and meal support such as helping to open packages, socializing, and encouraging fluids when needed. Sleep health by promoting more restful sleep routines and relaxation techniques. So delirium is defined as a disorder of global cerebral dysfunction, characterized by disturbances in attention, awareness, orientation, and cognition that develop over a short period of time and fluctuates in intensity and presentation over hours and days. Prevention and screening are important pieces in this puzzle, as well as early identification, appropriate management, and health teaching to the patient, family, and care provider. So at this point, we're asking you to please enter any questions that you have into the chat, and we will have time at the end of our presentation to address them. We're going to go into a case study. I want to introduce you to Victor. Victor is an 80-year-old gentleman with a diagnosis of prostate cancer for the past 10 years. He's had osteoarthritis and he has hypertension. Victor has been living with his son and daughter-in-law for the past 6 months since his spouse died. He spends his days watching his favorite TV shows and sometimes working on puzzles. Victor is at home alone most of the day as both his son and daughter-in-law work, but they do come home at lunch to check on Victor. Victor has been complaining of left hip and lower back pain and has increased his morphine content to 30 milligrams every 12 hours and morphine 5 milligrams every 4 hours PRN. He's taking acetaminophen 650 milligrams every 8 hours, ramipril 5 milligrams daily. He's taking Zytiga and he is receiving Leuprod injections. About a week later, his son comes into Victor's room and finds that he's sitting awake in his chair. He's been incontinent of urine, and his room was a disaster with books and clothing all over the floor. Furniture had been moved with Victor's mattress upended in his bedroom. He didn't recognize his son, and he was calling out for his spouse. He was moaning intermittently. His son and family were very alarmed and called 911. Victor was transported to the Emerge. In the Emerge, the son tells the physician that Victor has been very lethargic during the day and sleeping more. He's been up wandering at night, and his appetite has been poor with decreased fluid intake, and he's also been very nauseated. Victor, as per the son, has not had a bowel movement in greater than a week and has refused to take his laxatives. His son believes that Victor has been taking too many breakthrough medications, more than what has been prescribed. While Victor is in the ER, his behavior fluctuates from being agitated and calling out, attempting to remove his lines and climb off the stretcher, to being very lethargic. And he's also noted to have some myoclonus. So Kathy, what screening tool was used?
We used the 4AT screening tool, and Victor did score a very high score of 12.
Okay. And what type of delirium do you think he had?
Well, Victor is very confused. He's not able to answer questions. He's agitated. And at other times, he seems lethargic while in the emergency room. And he, in our eyes, we feel that he's sort of exhibiting a mixed delirium.
Okay. What other assessment tools were used, Kathy?
So we could have also used the New Desk or CAM as a screening and an assessment tool, but the other assessment tool that we used was the OPQ RSTU and V. So according to CCO guidelines, it was determined that victim's delirium, his onset was about 1 week prior to today, and Victor was at that time displaying some sundowning. The provoking and palliating, he was agitated. He was believed to be due to Victor's low back and hip pain, which caused Victor to increase the use of his opioids. The symptoms of delirium did improve with short walks, gentle reassurance, and reorientation. Quality, Victor experienced hallucinations, but presentation was very changeable. His region and radiation does not know the date or where he is. He could share his full name at times, and he continued to call out for his wife who had died 6 months ago. Severity, Victor was unable to apply any numerical values. His symptoms were difficult to assess as Victor could not communicate appropriately. So it was really difficult to know if he was in pain or the degree of pain that he was experiencing. Treatment-wise, he had been at home using far too many breakthrough medications. And in the past week, Victor was having, continued plus pain at home. Victor, for you, does not understand what's happening, and the family are very concerned and distressed. And undervalues, Victor's family, they just want, in their words, the situation fixed. They wanted him to be less confused and agitated, and they would like to take him home.
So Kathy, what do you think might be causing Victor's delirium?
We went forward and we used the mnemonic for delirium. And the D, of course, he had been using increased use of his breakthrough pain. So it was, anyway, he had increased use of his opioid related to his pain, and he'd not been eating or drinking well. We believe that he's probably dehydrated. He also had an observed myoclonus. So there may be some neurotoxicity happening. For E, he had an elevated calcium. His electrolytes were within normal limits, and there were no evidence of alcohol abuse or use. L, which covers liver failure, it was not an issue. His LFTs were within normal limits. I, he showed no underlying signs of an infection. All his cultures were negative. His urinalysis was clear, and Victor was afebrile. R, for respiratory and retention, there were no issues with Victor's respiratory system, and it was noted to be constipated as he had not had a bowel movement in over a week. He had no issues with increased intracranial pressure. Used for BUN, used for uremia for renal failure. He did have an elevated BUN and creatinine due to dehydration. His pain was an issue, and Victor was using opioids inappropriately at home. There were no metabolic diseases or imaging. We did not show brain mets.
Okay, thanks. What about the interventions? What were the non-pharmacological and the pharmacological interventions that were put in place?
So we requested that Victor and his family, we started out with non-pharmacological interventions. We did ask that Victor's family and Victor, if he was able, to report any hallucinations that might be frightening for him. We also asked the family to remain calm and provide gentle reassurance at the bedside and to avoid arguing with Victor. Nursing was also requested to provide a calm and quiet environment to reorient Victor to time, place, and person regularly. Allow Victor's son to be present at the bedside or a well-known family member. We ask that Victor's son bring in the client's glasses, hearing aids, and encourage the family to bring in familiar items from home, such as pictures and bedding, and possibly his favorite music to assist in calming him. We requested that the environment remain well lit during the day and that at night a night light be provided and not to leave Victor in the dark. We also requested the avoidance of physical restraints and bed alarms whenever possible, and to encourage activity if Victor was able. We also followed the moderate, delirium care pathway 2 was followed. Victor was treated initially with Haldol. He had an order for haloperidol, 1 to 2 milligrams sub-Q every hour PRN until his symptoms could become under control.
And then what conversations should the emergency physician have with Victor's family?
The physician should explain what delirium is to Victor's family, and that, he has no control over his behaviors and that it is related to his illness. They need to explain that delirium can fluctuate over time and that Victor may have quiet times and seem lucid and at other times be very agitated, that sometimes his behavior can be misinterpreted as pain or other discomforts. Mm-hmm. You need to encourage the family to remain present at the bedside and to be calm and reassuring with Victor. He also needs to discuss goals of care with the family. Victor's family should also be made aware that all efforts are being made to reverse the delirium and to make Victor comfortable, but that his condition is serious and that he may not survive this hospitalization.
Thank you, Kathy. During his hospital stay, Victor's calcium level was 3.24. The hypercalcemia was corrected with IV fluids at 100 cc's per hour, and he received bisphosphonates, amidronate. The neurotoxicity was resolved with hydration and rotating the opioid from morphine to hydromorphone with a cross-tolerance reduction of 40%. His bowels eventually became regular through treatment with Dulcolax suppository, and nursing was able to assist the client to drink a daily dose of PEG long enough to start having regular bowel movements. Given his decreased oral intake, his bowels were managed ongoing with the suppository every 3 days and ongoing laxatives. Victor also received radiation treatments to his hip and lumbar spine to alleviate his increased pain. Victor had a difficult course in hospital. He remained confused and lethargic during the day. He was occasionally agitated during the night, but was easily reassured and would return to sleep. Occasionally, he required a dose of Haldol, which was effective. Physio had attempted to ambulate Victor, but he was often too drowsy, and when awake, he would refuse. He was eventually discharged from the physio program. His oral intake was poor, and Victor developed difficulty swallowing. His PPS was then 30%. His medication was reviewed. Hydromorphone was then administered by continuous sub-Q infusion, and all other routine medications had been discontinued. The palliative care team had a family meeting to discuss Victor and to explain that Victor was not improving and that he had entered the end-of-life phase. Victor's family was given the option to take him home to die, or they could think about moving Victor to hospice. Victor's son wanted to fulfill his wishes of dying at home, but he realized that Victor's care needs were greater than what he or his family could provide, and they agreed to a hospice admission.
So based on previous conversations between Victor and his family, the decision was made for Victor to be transferred to hospice for his final days. Victor never settled when he moved to hospice. He was having increased visual hallucinations, and he asked the nurse, "Did you see that? Did you see that red car go zooming by?" One night, Victor was watching the ceiling and seemed very frightened. The nurse asked him what he was looking at. Victor stated, "Don't you see them? They're monkeys running all over the place." At other times, he was sleeping, but would get very agitated and moan loudly. Victor was not eating or drinking, and the family was extremely disturbed by what they were seeing. Victor rarely ever recognized his son, and this was very disheartening for him. They requested MAID. The palliative care physician discussed MAID criteria with the family and explained that Victor did not have the capacity to give consent for MAID. The physician did discuss palliative sedation with the family, and they agreed with this treatment. This is a case of intractable agitated delirium. Palliative sedation was implemented, and within 3 days, Victor died peacefully with his family at the bedside. Thank you. You're muted, Sue.
Of course, one of us would have to do this, right?
Right.
That's the end of our presentation. Thank you for joining us. And does anyone have any questions?
I know there was apparently something in the chat that
There is one question, and I'll just read it out for you if that's okay.
Sure.
Okay, so the symptoms of delirium mimic those of many clients with cancer brain mets. Should the same process measures be used to address both?
Yeah, I would.
Yeah.
Yes, of course. It's symptom management. Even though it's brain metastases, they can cause this type of delirium. They do present like they are in a delirium, a lot of them. But yes, I would implement all of these same treatments, whether, you know, the non-pharmacological and the pharmacological.
Thank you. And we have another one here. Do you have any tips on how to talk to a family who brushes off signs of delirium as it's just their dementia when you have clinically determined that there's also delirium going on?
I think if you can educate the family on the differences, and that tool that we presented earlier is really helpful to determine the differences between delirium and dementia, and also to reinforce the fact that delirium superimposed on dementia, it can be very difficult to identify, but it can also exacerbate the level of dementia. It is, and it can just get worse, right? So it's certainly in the patient's best interest to have that assessment and treatment.
Thank you.
Welcome.
And does anyone else have any other questions that they would like to put into the chat? Or, oh, Dr. Hunter has a comment. Many people who have delirium and require neuroleptic develop EPS side effects of the neuroleptic, particularly stiffness. And I'm sorry, I'm going to butcher this word.
Akathisia.
That's it.
Akathisia.
And do require even small doses of lorazepam to deal with the side effects. So that rather than increasing the neuroleptic, it is important to be sure they're not having the side effect. Otherwise, increasing the neuroleptic could worsen it.
Make it worse. Good point. Thank you.
Yes, excellent. Thank you.
We'll add that into our presentation.
We will.
I think that's what's great about these echo sessions is it brings everyone together to have that full, all-encompassing chat at the end, and we all learn from it. I think it's great.
We absolutely do. Thank you.
Thank you.
And we have another comment here. Excellent coverage of delirium. It is, as you say, often mismanaged, especially using benzopines. Oh my gosh. I think we're all tongue-tied today. I often also have seen multiple times with liver failure symptoms where people stop giving the lactulose as they misunderstand its purpose. So best to order it as routine and how many stools you're expecting per day.
Exactly, to help with that encephalopathy. Yeah.
I've seen that happen often in hospital.
Well, that's wonderful. If there's no further questions or comments, I'd like to thank everyone for joining us today. And thank you so much, Kathy and Sue. It was a very sane and educational presentation. Very well done. And for all of our participants today, please remember to fill out our satisfaction survey. It helps us to grow and improve our presentation. You can either do on the link that you'll receive in the follow-up email, or you can scan the QR code on your screen. Thank you all so much and have a fantastic day.
Thank you.
Thank you.
Thank you.